Hello, everyone, and welcome to tonight's session of the Berkeley Forum. My name is Aparna Iyer, and I'm the president of this organization. We're incredibly excited to welcome you to our first multi-speaker event of the semester, a panel on universal healthcare. Before we begin, a couple of quick reminders for our audience. We encourage you to fill out the attendance form at tinyurl.com/UHC questions and to submit questions for our moderator to read aloud during the audience Q&A portion at tinyurl.com/UHC attendance. Those should be swapped. Before we begin, the Berkeley Forum would like to take the time to acknowledge that our events and UC Berkeley's campus sit on the territory of the Ohlone people, and that we benefit from the continued use and occupation of this land. It's important to us to recognize this because the Muwekma Ohlone people are still alive and present in the Bay Area and in Berkeley itself. If you're looking for more resources on Native education on campus, we encourage you to look to the Centers for Educational Justice and Community Engagement. And with that, to introduce our speakers, I'd like to invite up our moderator for the evening, Annika Singhania.
Hello, everyone. Thank you so much for attending tonight's session of the Berkeley Forum, a panel on universal healthcare. The format will be as follows. I will introduce each of our speakers one by one, and they'll present a brief 3-minute overview of their position. Our first speaker for tonight is Kahn. He is the president and CEO of the Federation of American Hospitals, the FAH, which is the national advocacy organization for tax-paying hospitals since 2001. He is also the founding member and co-chair of the newly formed Future of Health, or FOH community. FOH brings together senior leaders from leading health organizations around the world with the objective of influencing, transforming, and redesigning healthcare. Chip has had a long and distinguished career on Capitol Hill, specializing in health policy issues. Chip has appeared on Modern Healthcare magazine's annual 100 Most Influential People in Healthcare list since inception. He's also honored with the B'nai B'rith National Healthcare Award in 2016. I now invite Chip to say a couple of words.
Great. Well, it's a real pleasure to be here this evening, and let me be very quick with my 3 minutes. First, as Annika kindly introduced me, I've been around health policy for over 40 years here in Washington, and worked on the Hill and been involved in the development of the HIPAA confidentiality policy and many other policies, COBRA continuity to provide private coverage for those who lose or change their jobs, all kinds of efforts over time to protect patients, to provide better health care, and to provide coverage. I feel very strongly, and the hospitals that I work for feel very strongly, that all Americans should have health care coverage. And I'm going to make 3 points tonight. One, the difference between the United States and the rest of the world in healthcare, other than we spend more than others, is that most other developed countries have some kind of universal coverage. But what I think is important is that despite the fact that they all have universal coverage, it comes in many different forms. In the UK, it's national health insurance. In Germany, it's a private-public split with private, relatively private, government-mandated insurance. Many different forms of financing and many different forms of delivery. I say that because, going to my second point, what happened in 2010 with the passage of the Affordable Care Act, otherwise known as Obamacare, we got a framework that would enable universal coverage for all Americans. It was built on the framework of the current system. It recognized the employer-based system. It obviously kept the system Medicaid for the low income, Medicare for seniors and the disabled, and took the individual coverage market and created choices through an exchange with private insurance. It was a private-public partnership. I'm sure during our question and answer, we can get into the details. It hasn't been a complete success in terms of reaching its aspiration, partly because of the law. That got in the way in terms of Medicaid being applied through across all states. We can talk about that. And also we saw 4 years of opposition to ACA, the attempt by the Republicans to repeal it, and it is part of our great political divide. But I would argue that with ACA, we have the possibility of universal coverage, and we see in the current bill that Congress is considering as we sit here this evening that one, we can take the exchanges and add subsidies to increase the likelihood of coverage through those. We can take for the unemployed who had coverage in their previous jobs, subsidization of COBRA, which is in the bill, the $1.9 trillion bill that the Congress will pass. So I would argue that ACA is a framework that can allow for coverage for all. And with an administration and a Congress that has that as its intent, we can achieve that goal. Finally, my concern about Medicare for all, or any kind of national health insurance in this country, is that we do better, I would argue, with pluralism, that one size fits all is problematic, and that putting all of our eggs, particularly in a government program, not that our government programs don't do a relatively good job, but would be the wrong way to go. I spent many years doing Medicare policy on Capitol Hill, so I have a great understanding of the program. I do Medicare policy now for hospitals. And I'll just conclude with sort of one example of why we have to be very careful of making our entire system sort of a one size fits all. And my example is the following. In Medicare payment, it's very important what kind of hospital you are, whether you're a rural hospital or an urban hospital. And there's certain advantages in wages and in wage payment and others for rural hospitals. Let me tell you that in rural Manhattan, Columbia Presbyterian is a rural referral center. In rural Cleveland, Cleveland Clinic is a rural referral center. Frankly, we have over 300 hospitals that are rural referral centers. And you can say, well, they played the game, they played the politics. And in the $1.9 trillion bill, do you know that we don't have any rural areas in Delaware or Rhode Island, but both will become rural states if that bill passes? And I only use these examples because it shows that any kind of public program is going to be vulnerable to politics. And I think having a pluralistic system, a public-private partnership, does advantage us over time. But we can talk about that more when we get to the question and answer. That's my presentation.
Thank you so much. Our next speaker is Scott Cinder. Scott Cinder represents trade associations and companies, as well as both legislative advocate and a litigator, on a wide range of issues in state and federal trial and appellate courts, in state legislatures and Congress, and before regulatory agencies. He's affiliated with Steptoe and Johnson as partner and chair of the firm's Government Affairs and Public Policy Practice Group. He is also the chief legal officer of the Council of Insurance Agents and Brokers. Much of Scott's work is in the health policy area. Current projects include legislative work on a broad array of private health market initiatives, as well as regulatory work related to patient protection and the Affordable Care Act of 2010. Scott represents multiple trade association clients before the NAIC and the NCOIL on health policy-related issues.
I think that's my cue. Thank you. Thanks for that. Thanks for having me. I don't have as long or storied a career as Chip, but I have been doing health policy really since the beginning of my career. And I've been talking about health policy issues since I was a kid. Because my dad was a doctor and he brought his work home, and we've been talking about these issues really for 50 years. Look, I think the question isn't whether there should be universal coverage, but how you get there. And in looking at that question, I think that there are two underlying debates that we're not really having overtly, although Chip definitely triggered the first debate, and that is whether you have a single solution or whether you have kind of a multi-pronged solution that we have today. That's the first debate. The second debate, which I think is the one that's really undiscussed, but drives a lot of people's views on this, is the question, or should the answer be that everyone has access to the same coverage, or in creating a universal coverage platform, are you trying to ensure that everyone has access to at least a minimum standard amount of coverage? And that question and how you answer it drives you to different results. If you answer it that we should all have the same coverage, then I think it does drive a Senator Sanders type of universal Medicare for all, where that is the only game in town. If you answer it that you'd like to see more of the existing framework in place, and we should be sure that everyone has access to at least whatever we agree on is the standard amount of coverage, that drives you to a different place. Like Chip, I'm a believer in the ACA framework, and I think that we should build on it and perfect it. I also think that it's beyond just the payment mechanism, that there are issues beyond just the simple financing. They relate to it. So like the surprise billing issue that we can talk about a little bit later, and transparency and what that means in different contexts. We have a lot of new transparency that's coming online over the next 2 or 3 years for brokers, for other service providers, for hospitals, for insurance companies, that I think could really be game changers, not just in terms of how things are paid, but what ends up being paid overall in terms of driving some of the cost out of the system. So I'm very much looking forward to the debate and the discussion, and thank you for having me.
Thank you. Our third speaker is Rachel Liu. Rachel Liu is a professor at the Graduate Institute of Business and Management and a former dean of the College of Management, Chang'an University in Taiwan, where she teaches comparative health systems, health economics, and healthcare financing. She co-founded the Taiwan Society of Health Economics in 2008 and served as its president from 2014 to 2017. Professor Liu has also served as a board of directors at the International Health Economics Association since 2016. Over the years, Professor Liu has been appointed to serve on various advisory boards to the Taiwan Ministry of Health and Welfare, National Health Insurance Administration, and the Ministry of Science and Technology.
Thank you for having me. It has been a great pleasure to be part of the panel. My career actually started when I worked with Professor Bill Hsiao at Harvard University. That was between my master and my doctoral program. I worked with him for the first phase planning of an NHI program for Taiwan. And consequently, the program was implemented in Taiwan in 1995. So we have achieved universal health coverage goal in 1995. And after I have completed my doctoral study, when I came back to Taiwan and have a research on national health insurance policy all through my career. I was, as the anchor person mentioned, that I was appointed to serve on various advisory board for our for Taiwan Ministry of Health and Welfare, and especially NHI Commission. So I was deeply involved in the implementation of NHI ever since it was implemented. I think Taiwan we advocate this one single payer model. So there's only one national health insurance program in Taiwan. And so it's a monopoly as well as a monopsony in the healthcare market, so to speak. And we have seen, we have learned great lessons around the world, and we also have shared our successful experience with people around the world. Although Taiwan is more or less isolated from the international community, but during this pandemic, I think our NHI program has served a very illustrating successful example, which we may come to when we have a more discussion. But my take is that through Taiwan's experience, I definitely is a strong believer and a supporter of universal health coverage. We have seen cases that people's access to healthcare has been, and we keep, will be enhanced. Their access to healthcare will be enhanced, and as I mentioned, has been. And we also have seen our equity in healthcare financing, as well as access to healthcare. I think the most important issue why one country should have a universal health coverage is to enhance the financial protection for the people. And we have seen that goal achieved by various social health insurance programs around the world. And the major problem, of course, is the financing side. And there are many solutions around, and we have faced up and downs. We have run the program with a great deficit, and now it's we have a little bit reserves. But the issue is that when it comes to increase the premium income, then it causes political fights. And so we have many experiences in facing the public when it comes to financing issue. But if you look at the positive side, when people can get health care without medical impoverishment, and I think one would really believe the true value of a universal health coverage. And I look forward to have a more discussion on this issue. Thanks.
Thank you. Our final speaker is Adam Gaffney. Adam Gaffney is an assistant professor in medicine at Harvard Medical School and a pulmonary and critical care physician at the Cambridge Health Alliance. His research focuses on health equity, disparities in care for patients with lung disease, and national healthcare reform. He writes regularly for a general audience on matters of health policy and is an author of To Heal Humankind, The Right to Health in History, published by Routledge in 2017. He's also the immediate past president of the nonprofit research and advocacy organization Physicians for a National Health Program.
Thank you for that introduction, and good evening, everyone. I want to say thank you to the Berkeley Forum for inviting me. I think this will be a very interesting discussion tonight, and it was great to hear the other panelists. So I want to make the case in the next few minutes that the current framework, the current US healthcare framework, is failing. And it's failing so clearly in the wake or in the ongoing COVID-19 pandemic. And how is it failing, and why do we need to go beyond the current framework rather than merely build upon it? Well, it's failing in a number of ways. Number one, we still have not achieved anything close to universal health coverage in this country. Even before Trump, there was about 30 million people uninsured in the United States. The number went up by about 2.3 million under Trump. And since this pandemic has hit and the economic dislocation that it has rendered, millions have lost their jobs, many have lost private health coverage, and it's likely that the uninsurance rate will rise. This is a matter of life and death. This is not a matter just of dollars and cents. The study after study has shown that leaving people uninsured translates into death, translates into early mortality. And as mentioned, I am an ICU doctor, and I've certainly seen the downstream consequences of people being left out of the healthcare system, conditions like hypertension or diabetes that are left untreated, and people wind up with emergent, acute, life-threatening complications because of it. So this is not something that we can simply, slowly, incrementally build towards, and maybe in 15 years we'll get another 4% covered. We need immediate universal health coverage, and the best way to do that is to cover everyone with one system. Now, I want to make a separate point, which is that this discussion is not just about who is covered. It's also about how adequate the coverage is. And the truth is that we have an epidemic in the United States of underinsurance. So the problem is not just uninsurance, meaning no health coverage. The problem is also underinsurance. Depending upon how you define it, at least 44 million Americans and rising are underinsured. This means they have copays or deductibles that are so high, it's almost as if they don't have health coverage at all. And the data shows that there are very harmful consequences. Women with breast cancer delay biopsies and even the initiation of chemotherapy when they have these high out-of-pocket expenditures. Kids with asthma don't use their inhalers. Patients like I see with emphysema don't fill their prescriptions because the costs are too high. And just a recent study suggested that these kinds of cost sharing co-payments, deductibles actually increase mortality among seniors. So this is another urgent problem that we have to address. And the way that you address that is by creating a new framework, a national health insurance that actually doesn't just cover everyone, but expands coverage for those who already are insured. And we've seen this is how it works in Canada. You never pay a copay to see a doctor in Canada. You never pay a deductible if you get hospitalized. And it's true in the United Kingdom as well. In fact, in Wales and Scotland, you'll never even pay a penny for a prescription drug. The final point I'll make, and then very much looking forward to the discussion, is that the question always comes up, how do you pay for it? Fair question. We got to address that issue. And one big way you pay for it is by cutting out the enormous waste of the American health insurance system. The Congressional Budget Office, nonpartisan obviously, Congressional Budget Office just released a working paper analyzing Medicare for All and estimated that transitioning to single payer would save $400 billion a year just by getting rid of the incredible waste of the health insurance industry, which creates a multiplicity of arrangements and contracts and different payment modes and so on and so forth. So I want to make the point that we need to address uninsurance, that we need to address underinsurance, and we need to be able to pay for it. And the right way to do that is moving towards a simplified, more egalitarian national health insurance Medicare for All system. So thanks again for having me.
Thank you, and thank you all for your addresses. We will now be moving into the moderating portion of this event, where I will be asking questions to all of our speakers, and we will alternate as they provide their answers. So kicking off with my first question, universal healthcare is a broad topic, and there are many proposals for how the US might go about implementing it. What kind of universal healthcare system do you believe is most ideal or feasible? And anyone can start off by answering this question.
I think the word you used, feasible, it's got to fit into our political context, and it has to be, I would argue, close to what people are used to and feel comfortable with. And issues of comprehensive coverage versus too high deductibles, all of those can be dealt with in the context of ACA. I would differ with Adam on that. And second, I think we have to realize that we have at best a 50-50 country, and 50% of the people in the country are for repealing the ACA. It didn't happen during the Trump years, but that was the reality. So in some ways the ACA is a hybrid and a compromise, but I think we can only live with what's possible. If we tried to leap all the way to where Adam's going, it's not just even a question of goring a lot of oxes. You would have to have tremendous regulation of fees and provider activities. And I would argue that just the complexity of setting that up would lead to a system that I think we would all be very sorry about when it actually happened.
Why don't I pick up on that before Adam tears it all apart? So what I would say, completely in line and sort of building on what Chip said, is look, some of this is included in the ACA, right? The idea that Medicaid would expand, it would become richer, if you've got about 30 million people right now in the United States that are uninsured, and then you have another, I'll take your numbers, Adam, 14, 15 million people who are underinsured, a huge chunk of that comes in states where they haven't expanded Medicaid. So my brother-in-law lives in Texas. They have not expanded Medicaid, which means that they have a donut hole in their system. He makes too much money to qualify for Medicaid and not enough money to qualify for a subsidy on the exchange. There are 5 million people like that in Texas. That's a big number. That's a sixth of the 30 million people alone that aren't insured. It's crazy. So I think that we need to fix that. There are things that have been done, like with the reinsurance programs under the Medicaid waivers, 1332 waivers. They are having an enormous impact. Rates in Colorado, in the individual market, they're down 30% year over year since they instituted the reinsurance program. And the idea there is that you make as a public burden, essentially, claim amounts, any individual's claims that exceed a certain threshold when they have cancer or some other high cost condition, so that you make it easier for the insurers, who I won't defend, I don't represent, but you make it easier for them to price to the mainstream because they cannot worry as much about that high cost stuff. So there are, I think, lots that we can do to expand that Medicaid safety net, to enrich it, Adam, so that it covers more as you say it should. And I don't disagree with the word you said on that. But I think if you're going to go and replace it with the new system, you have the political practicality. You also have the fact that today you have 160 million people that are covered under employer plans. They like it. There's a lot of efficiency in it. They know what they're getting. You can couple it with wellness, and we're still really at a nascent stage in terms of the impact of different wellness programs, but to deliver them through an employer is impactful. And so that's how I would get there. I would build out the Medicaid safety net. The only other thing I'll say before Adam tears it all apart is this. In the ACA, there's a provision that required the administration, the Department of Health and Human Services, to create a national plan. It would be an option. It wouldn't be the sole single payer. That national plan, the idea of it was that it would be a streamlined plan, that many states have imposed different mandates that can add expense and complication when you're selling plans on a nationwide basis. Any state that chose to impose a mandate beyond that national plan could do so, but they would have to pay any subsidy that was associated with the extra benefit. The Obama administration started down that road, and the different players came out of the woodwork. Everybody wanted their benefit in. They ended up punting and said every state can keep their same basic framework, and that'll be the basic plan. That's a pretty rich basic plan for the individual market, which drives some of those premiums and deductibles. That's an opportunity that we haven't yet taken advantage of. And so you could couple that with the Medicaid, and you could develop cheaper plans and plans that everyone can access. Adam, I'll leave it to you.
A few points. I mean, first off, I mean, Scott, I don't disagree that Medicaid expansion could be something that would be useful right now, and I certainly support that. And in states like Texas, they're leaving a lot of people sort of uncovered for no particular reason, and it's pretty terrible. But that sort of short-term goal doesn't conflict with pushing for a broader, deeper, and necessary transformation. A couple of things why on the policy side, I still very much think Medicare for All is the way to go. The reality is that a simplified financing system achieves efficiencies that you just don't get with other approaches. I mentioned the CBO report recently. The CBO asserts, and we've been saying this for a while, that traditional Medicare has about under 2% overhead, meaning 98% of total revenue, total Medicare spending goes to healthcare, 2% is consumed in its administration. Private insurers, it's closer to 12% or higher. That's an enormous amount of money when you're talking about an industry that's $4 trillion, right? And then on the provider side, U.S. hospitals consume about a quarter of all their revenue on administration. CBO says 19%, another study says 25%. Either way, it's an enormous amount of money. And the truth is that countries that pay their hospitals in a simpler fashion, like Canada or Scotland, the hospitals have half the administrative costs. And those costs are bundled into the price we pay for healthcare. Now, by moving to a simplified system, you achieve those efficiencies, you achieve those savings, and that allows you to expand coverage most fully, cover everyone and expand coverage for everyone else. If you don't achieve those efficiencies, invariably you're left with either a more expensive system or paltrier benefits. So my argument is that to achieve the benefits, to achieve full universalism, to eliminate financial barriers to care, to actually have free point of use healthcare, which we know is possible, which they have in Canada, then we need something on the other side of the ledger to balance the costs. And a simplified financing single payer system is the way to do it. If you don't do that, you sacrifice those savings, and then you're left with the deductibles, or you're left with the uninsured or the underinsured. So that's the policy argument. Politics, we can talk about all day. Yes, there's no question that achieving Medicare for all would be a major political battle. It already is. It's already been in the news. It's been, the center point of the last two Democratic primaries. But even in my life, even since I've been involved in advocacy around this, I've seen an enormous amount of forward progress. An issue that was actually more on the fringes, 5 years ago, that now is supported by 2/3 of Democratic congressmen, congresswomen, and congresswomen. That is progress. Bernie Sanders, we mentioned his bill. He used to have the only supporter of the single payer bill that he put forward every so often. And now there's, I forget the latest count, but the last version I think had 16 co-sponsors. That may be off by a senator or two. But that's a progress. And so at the current rate we're moving, I do think this is achievable. And there is opinion polls showing a majority support. We do have a long way to go. I'm definitely not opposed to achieving incremental gains in the meanwhile to improve people's lives. But I do think that we should continue to push for that as the long-term goal.
Yeah, I want to echo Adam's point in terms of administrative cost. I think the way that Taiwan is a successful example exactly because we have a single payer system, which will reduce administrative expenditure, substantially. For example, our administration expense is only roughly 1% of our total national health expenditure. And the reason we can do that is because we have this one single payer system. So every provider we have a uniform claim filing system and all electronically done. And we have this big data to profile physicians, to profile patients. So we can just identify those high-risk people or people actually overuse or in a way unnecessary healthcare in an instant, and that we will be able to sort of manage these cases because we have the data. So if we have one single payer system, the power of data is actually a key success to how to run the program and manage is cost. Obviously I'm based in Taiwan. I cannot, say anything about U.S. healthcare. But one thing is that Taiwan, we only devoted roughly 6.5% of our GDP on healthcare. Meanwhile, we cover 99.9% of our population. We do have a co-payment system, but it's monitored. And actually, there's a big discussion whether we should actually increase the co-payment to cut down the sort of wasted, the wasted health resources. And so I think that's definitely an advantage of doing single payer system. But it also goes with, how the society views single payer system. And one thing I actually want to put, I want to ask our American panelists is that how do the majority of the US people see social solidarity? Because for social insurance program to work, people have to believe in social solidarity, which means high-income people should help or subsidize low-income people, and low-risk people, in a way, subsidize high-risk people. And if you believe in social solidarity, then there's a consensus in the society which may make this program easier or more feasible. And so social insurance program like Germany or Taiwan, the reason we can do so we can implement national health insurance program to achieve universal health coverages. There's a big consensus in our society that social solidarity is the social value, or the core social value in the society.
Thank you all. So some would argue that the main pushback for accessible and affordable healthcare is from private companies and their political influence. What strategies, if any, would be the most effective in pushing universal healthcare to the forefront of legislation? And like this one, anyone can start again.
Well, I'd like to answer Rachel's question in answering that question. And we can, I don't want to value judge it, but I think this country is based, for at least many of us, or a large portion, on individualism, not social solidarity. We have social programs like Medicare and Medicaid, which became accepted because they passed at a certain time and became part of the social fabric. But the effort to go beyond that has been extremely difficult. And that's why I think, in terms of reaching where we want to be with universal coverage, we've got to do it in such a way that lives within the culture that we have. So I think that the idealism of Adam is great, but let me also say that in some of these countries, the amount of funding and wealth they decide to devote to health does make a difference in the healthcare. And I think I'll say something that I'm sure is going to get me in trouble, but I think if we look at the policies, particularly in the UK, about the people that were taken care of in the NIH who had COVID, there was an arbitrary decision that seniors were generally, in the nursing homes, were generally, left there. Clearly it was the case in Sweden, and it was the case in the UK also. So I think that reflected, because the stress of COVID on the NIH was incredible. Actually, the stress on our system, once we got a handle on it, was at least manageable. And yes, there were moments, I think, in New York City at the very height, but by the time we got beyond the beginning and we righted ourselves in terms of PPE, we figured out sort of how to treat most of the patients. We have been able to handle COVID, at least in the hospital system. I think we've done as good or better job there. I won't talk about the public health side. And frankly, if we had national health insurance, it wouldn't help us on the public health side. That's a completely different issue in terms of what part of government handles it. So, my argument, I guess I'm just a broken record, is we have a framework. We ought to figure out how to make that framework work better, because it's just a leap too far. One more point. I think this notion of insurance and reducing the cost, first, there's the 400 billion includes a lot of things. And frankly, doing business with Medicare and Medicaid is not so cheap. That 2% is simply what the payers receive from Medicare to pay the bills. The compliance with government programs is frankly more expensive on the hospital side frequently than it is with private payers. So I'm not sure that we'd have some kind of halcyon day. And frankly, if you spread the kind of comprehensive coverage you're talking about, which would be super, across all the people, it's going to have an effect on what can be paid, because ultimately it's not just closing down the insurance companies that's going to make a difference here. It's also, you're going to have to ratchet down on what people get paid. And at that point, you will affect access to care, because we won't have all the hospitals and we won't have all the doctors staying around.
I can jump in here. So we have a couple interesting threads, I think, of this discussion. One is the question of social solidarity. I'll just say briefly on that point before addressing the other ones. I think social solidarity is not just something, it's something that is made by movements, right? Medicare didn't just come out of the blue. It was a combination of civil rights, of senior citizen groups, of labor groups, and people worked on it for a number of years and achieved it. And you know what? Seniors, about half of seniors before Medicare was passed in 1965 had some kind of private health insurance. So we've had transitions in history where we've gone beyond what existed before to something new and something that was better. And Medicare was much better, and it was a major advance. It didn't go far enough, but it was important. In Canada, when they implemented their national health insurance, they had Blue Cross and other insurers. They existed, and they moved beyond that. And I think that, at the time that Canada created national health insurance, or the time that Britain created its National Health Service in 1948, they weren't fundamentally different as a nation in terms of values. There was different political circumstances, and who had power was different. But they created universal healthcare systems that then in themselves helped create social solidarity, because people realize that they're all in it together. Once you create these programs, people like them, and they're very popular. The NHS, despite the fact that it is underfunded, is very popular in Britain. The founding father of the Canadian healthcare system, Tommy Douglas, is sort of regarded as a folk hero. And Medicare in this country is actually extremely popular. As politician after politician has learned, who has tried to privatize it, it's not so easy to take on. So I think social solidarity can help create programs like national health insurance, but I also think national health insurance can help create social solidarity when people realize that they're sort of in this all together. In terms of some of Chip's points, so a couple things. First off, the question of the Medicare administrative costs. Chip mentioned that the compliance among hospitals with Medicare's rules can be just as expensive or more expensive than private insurance. And there is some truth in that Medicare over the years has developed all of these new complex pay-for-performance measures and systems where you sort of get paid more if you meet all these different metrics, and those have been very expensive, and other sorts of programs have been expensive. And so when people speak about improved Medicare for all, they really mean a lot with the improved prefix. The idea here is not just to recapitulate the existing Medicare program with all of its warts and flaws. The idea is to reform Medicare into a much better program, not just getting rid of some of these wasteful sort of requirements and pay for performance metrics, but also Medicare frankly has copays and deductibles and the things that I'm criticizing as well, and so that needs to be changed. To say nothing of no long-term care coverage. That's another important thing to deal with. So the reality is that when you speak about a big change like this, it does seem insurmountable. But the truth is that throughout American history, throughout the history of many countries, major achievements have been made. If you look back at the civil rights movement, if you look back at Medicare, if you look back at many other seminal moments of history, there's probably a moment where these things seemed unattainable, but they were attained. And I think that's possible in the modern era as well.
Yeah, I think it leaves the question about should they be attained. And one comment I would make to you, Adam, is reform Medicare first before you think about expanding it. Right? I mean, from a sequencing perspective, let's try to get it right to where you think. But one thing those experiments are designed to do is to try to find ways to better deliver care to people for less and to have better outcomes. And you haven't talked as much about outcomes, but a lot of those people in the UK and Canada, when they have a major issue come up, they come here to get taken care of. Now those are people who can afford it. And so they separate themselves that way. But I would argue there's at least a couple things that underlie this. One is there's a US elitism that maintains, right? We think we pioneer at the frontiers of the medical system. And that's not done through a social welfare type approach if that's your sole payor, A. B, in terms of our current social cohesion, we're obviously not there. Now, maybe this is a movement that could change that. But I think one of the reasons you have those 12 states that haven't expanded even their Medicaid programs is because they're so divisive in what they've done. Now, look, Medicaid was created, I think, in 1967. It was a state opt-in. It was what's that, 65? Yes. It was a state, I think, anyway, it was a state opt-in program. The last state to opt in didn't opt in until 1982. So it took a long time just to get to that basic frame. At some level, as quickly as we want to move, we end up moving glacially a lot of the time. And then there's a moment when it all happens like that. But, look, from where I sit, I don't know that there's a lot of people who are very satisfied with where we are, who it's delivering well, who feel like we're best in class. And I think the question is, how do you preserve that while at the same time creating a robust social welfare net so that everybody has access to what they need?
I actually wonder how much the government help to subsidize the program, or is there any estimate? In Taiwan, currently, the government is by law is supposed to provide 36% of our total national health expenditure to help finance the program. And obviously, financing is always an issue. And then we always talk about political will. And so when you talk about developing strategy, I think politics seem to be the key obstacle, or hopefully it can be a key driving force in the process. I certainly think that in US, this is more complicated than in Taiwan.
Got to say one very brief point on the question of outcomes. Scott and Chip, I think it's not quite the way you phrased it. I mean, we all know that the U.S. has lower life expectancy than other, European nations. Admittedly, life expectancy is affected by a lot of things, as Chip points out. Public health is separate, but even when researchers look at what they call amenable mortality, meaning mortality amenable to medical care, we still come out behind many of these peer nations. I remember a study in the Annals of Internal Medicine a couple of years ago that looked at cystic fibrosis. And this hits close to home because I'm a lung doctor, but they found that Canadians with cystic fibrosis lived about 10 years longer than Americans. So there's no question we do have top-notch facilities. And I think we, have excellent hospitals. And I agree with Scott that we want to retain the best of what we have. But there's also the fact that people can't get that care equally and equitably. And as a result, we don't have the kinds of outcomes as some of these nations that actually make it accessible to all.
But I think there you really need to go condition by condition, because I think if you took cancer here versus cancer in the UK, we would do a lot better than the UK. I think it's a little unfair if you compare comparable populations. Part of our problem is that the social determinants of health, some of our communities are undercovered or have lack of access. And I don't want to excuse that, but I think the point that Scott makes is if we could figure out how to get everyone up to that level of coverage, then I think we could solve a lot of these problems. I'm not sure, but I really think you've got to be careful with comparing how we do on outcomes, because it really does vary a lot all over the map, depending on where the priorities are that the public programs in those countries decide to put their effort into.
Thank you, everyone. So while some critics of the universal healthcare system argue that it may hinder medical innovation, others say a well-designed system could support the development and implementation of cutting-edge technology. How, if at all, could a universal healthcare system be molded to support innovation in biotechnology and in pharmaceuticals?
I think that at least in terms of biotechnology and pharmaceuticals, I think there's a big question. And the question is, if you ratcheted down what's paid in the United States, would we have the innovation across the world? Because most of the world regulates their drugs, and we don't regulate the prices. There is some regulation inside of Medicare and Medicaid, but it only has a marginal effect. And frankly, the drug companies make money on the margin in Europe, which is regulated, and they make a lot of money here. And their argument would be, if you squeeze this down here, there wouldn't be enough. I don't know what the reality is, but at least that's how the industry looks at it. And I think it's a big question mark.
There's a little bit of a semantics issue. I think we all support, all four of us, universal coverage. So that's not the issue. The issue is it a single payer type system like Adam is expounding, or is it something more incrementally grown from where we are today? And I would argue that that's exactly what you put at threat with that single payer type system, is some of that growth and innovation. as you sort of achieve your outcomes. And one place to look is in the private market subsidization of the Medicare market in the United States. The Medicare market doesn't cover CHIP's hospitals' costs for those procedures. The private market does. So right now, some of the subsidization that has been spoken about, it goes from the private market to the public market to support that level of care. And I think it's difficult to support the type of innovation we're used to in a single payer structure. Now, that would be my view.
And actually, to answer Rachel's question, let's just take the private coverage that employers provide. That's tax excluded, which means there's about a $300 billion a year tax expenditure for private coverage. The other part is paid paid by the individuals. So we have a tremendous federal expenditure between tax expenditures, direct expenditures for Medicare and Medicaid, premiums that are collected from seniors. So we have this pluralistic system, and there's a lot of money in it. Now, there's a lot of inefficiencies in it, and I'm not going to excuse that. And that's one of the reasons we spend so much money, but not the only. And one other point too is that even in Medicare, what is the future of the Medicare program? The private insurers, in a sense, are taking over Medicare. We'll be at way above 50% soon of Medicare beneficiaries being in private plans. I think actually they're probably a little bit overpaid, but it's very attractive because they can offer various benefit packages. But that's the probable future of Medicare unless policy changed.
On that point, Rachel, do you have something to add to the points that have been made?
Yeah, when you talk about new technology, high-end medical technology, yes, I think in all, if not all, most of the social health insurance program that I research, many in Asia, they all have to put a cap on the adoption, some limit, constraint on the adoption of medical technology. In the case of Taiwan, we have a long process to make the decision whether new technology will be covered or not. So for that, private health insurance market, could be a potential, supplementary private health insurance could be a solution for some people that they can take on so that they can buy high technology, which is not covered by our current national health insurance. But I think the key thing for any country which has a social health insurance program is sustainability. And so financing comes into the picture. And so they need to, become innovative to sort of contain the cost. And high-end medical technology, advanced medical technology is definitely a big deal, and that the administrator will need to pay attention to. And so in a way, it probably hindered the process. But I like CHIPS. We don't know the true story is, but constraint on the adoption or the pace of adoption medical technology is necessary.
Just if I could say one thing about and thank you, that's an interesting perspective on it. And, in terms of going back to the question for a second about specifically the research and development aspect, which I think was the question, the truth is that this comes up a lot. What would happen to sort of, innovation and research under single payer? It's important to note that the private health insurance companies are not doing any research whatsoever. I mean, I don't think anyone can name a medical, a pharmaceutical drug or a treatment or a surgical procedure that was developed by Aetna, Cigna, or United Healthcare, right? The private health insurance companies are not doing medical research, at least not any that has any particular importance. And so the truth is that transitioning to Medicare for all is not going to have any impact on the vast majority of research, which is happening in academia is largely funded through the National Institutes of Health, and that would continue. Now there always is the question of, if you lowered, and Chip was getting at this, if you lowered drug prices at some point, would pharmaceutical companies stop investing in R&D? And I suppose certainly they would at some point if you lowered it low enough. But the truth is that there's a lot of fat there that we can trim down on, right? Monopolistic pricing is what we have now. They sort of set the price and we pay. And there's certainly some, I think almost everyone agrees that there's some fat that can be trimmed. And even if you are worried that at some point that's going to translate into some reduction in R&D, well, look, we can simply put more money into the NIH. We can directly fund the development of new drugs. There's no, there's probably a need for more medical research, so let's fund it and let's do it publicly. But I don't think there's any conflict there. And I think, the point that, Rachel, you were making about limits on the adoption of technology, there is a discussion to be had there. And I think sometimes we've seen, in the United States, a dissemination of technology even beyond where it's useful, and that's a separate question.
So just two quick things. One, our doctors are paid more than twice as much as doctors in any other country in the world. If you have a single payer system, that will change. And that's the beginning of the change, right, in terms of the downward price pressure on providers. The second thing is, if you're only funding research and development through the federal government, you now have essentially a totalitarian system where decisions are being made centrally. One of the strengths of our system has been we don't do that. And so that, you can downplay the impact in that space, but I believe to this day, we lead the world in terms of medical development. You would be directly putting that at risk. And at some level, you can make the argument it allows other countries to more quickly socialize their medical structures because they can rely on us to continue to lead in that space.
Yeah, and I hate to be cute, but I'm going to use COVID again. In terms of the last 6 months, what's the most successful aspect of COVID? It's been the development of the vaccines. What's been the most unsuccessful, or at least slow, and frustrating, and not well developed or implemented, and that's been the logistics. Now, we can blame the last administration, but this administration is still having the same problems. Government, at least in our context, has a lot of trouble doing some of the things you're talking about. The miracles of NIH are one thing, but actually the vast delivery of services is another, and we would really have to change a lot to make that successful. I would be a little bit terrified to put all our eggs in the basket of government in terms of all those aspects of drug development. Now, maybe the Soviet Union and maybe the Chinese company that did the vaccine were great, and I don't know their structure, but I guess whatever you think about the pharmaceutical companies, I think at least in the context of what they've done right now, they were able to do something that I don't think any other organizations could have done in that time. Now, they got paid a lot of money for it, and that's what made it possible. But we have a crisis, and we needed to go to the best.
Huge amount of taxpayer financing of those vaccines.
Yes.
So unfortunately, that's all the time we have for my questions. We will now be moving into some audience questions. So this is from an anonymous individual. According to the CDC, people of color are significantly more likely to be hospitalized and to die from COVID-19, highlighting racial disparities in access to quality healthcare. How, if at all, can transitioning to universal healthcare help ensure more equitable access to medical care? And we can start with you, Adam, because I think you had a point last time as well.
So it's such an important question. And like in so many ways, the COVID-19 pandemic has laid bare the inequities of our society. There has been an enormous disproportionate amount of death in communities of color. And look, I mean, there's a few things going on there. There's occupational risk. Some people are having to work in these dangerous jobs, others are not. There is household crowding. There's all of this sort of social and economic inequalities, but there's also a healthcare system that is frankly, has structural racism built into it. Right now in the United States, who has the highest uninsurance rates? Black and Hispanic people have much higher uninsurance rates than do white people. Given the wealth gap, you're going to simply, the reality is with gaps of income and wealth, that's going to translate into significant burdens in terms of copays and deductibles for some families more than others. And we can also just get into the fact that there is a separate but equal healthcare system in many ways. There is some underfinancing of hospitals and healthcare facilities in communities of color, and many, in communities that are prosperous and wealthy and white, hospitals are maybe richly funded and are building giant new atriums, while other hospitals are closing in poorer and poorer communities. So the question is, how do you deal with that? So obviously you can deal with uninsurance through national health insurance, deals with that. You can deal with underinsurance, and as we spoke about, through copays and getting rid of copays and deductibles under our Medicare for All system. But also this framework allows you to reinvest and put funds and build infrastructure and expand infrastructure on the basis of need, not just on the basis of profits, which right now is often the driving force in where we see new hospitals growing and some hospitals falling and closing. Obviously, there's the issue of biases of providers as well, and that's still going to be there, and that's something that has to be addressed. But these structural factors, uninsurance, underinsurance, and the geospatial inequities in the distribution of healthcare infrastructure are things, in fact, that you can address through a health system, a unified health system.
On that point, Rachel, do you want to add something there?
I think in the case of Taiwan, we have a rather homogeneous population, but that doesn't mean inequity doesn't exist. Mainly it's between different socioeconomic status population, but it's mainly because our program charge very minimal copayment, and so people really have full access to health services. But it depends on where they live. If they live in a rural area where the supply is less sufficient, then we definitely see a lower use rate. But for that, our NHI program actually developed some services, like services on the wheel. So they actually ask the doctors to go to the rural areas on a regular basis, like maybe to 1 or 2 clinics every week to look after their people living in the rural areas. And I think so on the delivery model, as long as there's a financing, there's the insurance, they are covered. The insured as NHI administration will mobilize the services in the city to help people in the rural, so to resolve the issue in terms of inequity in healthcare uses.
I think this is a huge problem. I will say, though, at least in terms of the hospitalization side of it, we basically had national health insurance because the government paid for all the COVID costs for hospitalizations. Now, whether people felt like they had access to hospital because of their relationship with doctors, whatever, there are a lot of issues. But I think this is one where if we had even a simple national health insurance system, I'm not sure we wouldn't have still had, unless we had tremendous programs, public health and other programs to deal with the community, that we could have, we would have not suffered from issues here. And I think if you go to the UK, you'll see that communities of color there had a much worse experience, even with national health insurance, with COVID, for a whole lot of social reasons, structural reasons, class reasons, and maybe even in some cases genetic issues. And so I think we want to get everybody covered. It's an important ingredient, but it's not. This is a much bigger problem than just the literal delivery of healthcare. I think we have to recognize that.
There's no question that social inequity causes poor health beyond medical care. I mean, that's absolutely true. I don't think there's any evidence for genetic etiologies for racial disparities.
Well, no, I mean, I think in terms of issues around vitamin D and some other things, there may be some differences between ethnic groups that actually are affected in terms of their outcomes in COVID. I mean, I think there may be. I don't. I mean, I hope that's. I'm not being politically incorrect in saying that, but I think there's some. I'm not. There's some evidence of that. I know there was evidence in the UK. There was definitely evidence of that in terms of the Indian community. There was some literature on it.
You know, I'm going to save you, Chip. I think the bigger point is where we started, and that is that clearly we have a problem. Clearly we have underserved communities, and we have to fix that. I think that there's a number of different ways to fix it. I think we just have to fix it.
Our next audience question also comes from an anonymous individual. So one of the concerns brought up by the universal healthcare is that it may lead to abuse, for lack of better terms. For example, some people may be less likely to take personal responsibility for their health, knowing that there's universal healthcare. Does anyone have thoughts on this?
Well, moral hazard is almost an unavoidable issue in any insurance design. So, you know, like I mentioned at the very beginning, that we actually profile patients, you know, for those high use patients, they're actually looking to their use pattern and case by case, and even had the NHIA, our National Health Insurance Administration, will then will designate some certain provider, like the provider that this one patient the high use patient frequently visit to make house call and to know, you know, what's going on, why they use the services so much. It turns out most of the extremely sort of high user tend to have some psychosis problems, and then they really do case management to lower down their rates. And over the years, we have seen the rate, you know, the use rates come down a bit. And so again, you know, only a single payer will have the big data, will have the power of data to really look into the operational issues and profile patients and even profile providers. I think that's just, you know, one example that I can share with you.
Can I say two quick things? One, I don't think we've seen this issue in Medicaid. And Medicaid is essentially a public program that has a lot of the bells and whistles, maybe not as rich as they should be yet, that Adam identifies. So I'm not sure I buy into the moral hazard piece. But the other thing I would say is there's two questions, right? How do you get people better when they get sick? And that's really where we've been focused. But what I think is most interesting is how do you keep people more healthy and not have to take advantage of all the fancy medical facilities? I feel like we're not that far along yet in our on the learning curve in terms of how we do that. We're still experimenting. And I don't think that a national healthcare system necessarily helps you advance that particular objective. I think that having a lot of different players experimenting and finding different angles on it is what gets you to the end of the day. And we have a lot going on that right now in the wellness space. It's interesting, and it hopefully will bear fruit over time.
Yeah, I agree with Scott. I think there's only so far we can go with healthcare delivery. And I think addressing Adam's point about length of life, I think in this country, issues around social determinants of health are big, and also even in populations that have sufficient, you know, have wealth. You know, we have risky lifestyle. I mean, obesity is a tremendous problem here, and the healthcare system receives the problem, but it isn't geared to stop it, and it's lifestyle. And I think we have to face that's a public health issue. It's an education issue, and it's an issue that even if we had all the healthcare for everybody, it's not necessarily going to lead to better lifestyles, which clearly would reduce stress on the system and help people live longer.
You know, I think I would say a couple of things. I mean, I think the initial question was something along the lines of like, would universal healthcare cause people to make riskier decisions, with the assumption that I guess everything would be covered. And I can't think of anything I'm less worried about in the entire world. Like the idea that I'm going to start smoking just because if I get lung cancer, I'll be able to get chemotherapy. It's just not how human psychology works, thankfully. Otherwise, everyone would smoke in Canada. So the question is, I think the moral hazard question about do people use too much healthcare when it's free, that's been discussed, and we heard a little bit about that. Again, I'm not really particularly worried about that. Yes, people use some more healthcare, but unfortunately, for better or for worse, people don't like going to the doctor. They don't particularly like chemotherapy, and they certainly don't like the intensive care unit. So for the most part, we don't have to worry too much about the overuse question. And we have, countries in the world, again, like keep going to Canada, but it's closest to us, and that's for a reason, where they don't, they have no co-pays for doctors, and they go to the doctor, similar number of times a year as we do. But look, I mean, just to go, so this came up, this question in the last one, which is, how much difference does medical care make? And, as a physician, I'd like to think it makes a big difference. The reality is, it's true. It only is a really small piece of the overall health problem. I don't agree with Chip that it's really about lifestyle. I do think that we have bad social policies, and we have oppression that results in poor health, both along racial and class lines. We actually smoke less than French people do, right? I mean, that, there's a lot here to unpack, and I would agree that there's more we need to change than just the medical care system to give us all healthy, long lives and to reach health equity. But I think I have a different sort of idea in mind of what that would involve.
I just wanted to clarify. I think the magnitude of a moral hazard depends on the type of services. For example, if a visit to a physician visit, you tend to have a higher degree of a moral hazard because it costs you nothing. Diagnostic test, all the testing which it doesn't require too much, blood drawing or painful process, it's going to have a higher degree of a moral hazard. It really depends on the type of services, and it's well evidenced in health economics literature.
But remember, few people are sick at any given time, and actually a very small percentage of people spend most of the resources, and the people that spend most of the resources are really sick. I mean, that's true in every system. So I just don't see this as being that big an issue. At the margin, if it was free and this notion that you could go all the time, you'd have some overuse of doctors probably, but really it's the people who are truly sick who spend most of the resources in every system.
Yeah, but that's different from moral hazard.
No, I understand. I understand.
Thank you, everyone. So unfortunately, this will be the last audience question just for the sake of time. So on the point of Canada, some publicly funded healthcare systems, such as Canada's model, have experienced long wait times. So what strategies, if any, would be effective in mitigating these wait times to ensure timely and quality care?
Well, I think in the case of the UK, they just increased the pay to the doctor, but that certainly should not apply to US, I suppose.
You spend more money.
Yeah, I mean, I think I agree with Chip in that the reality is, look, at the end of the day, the US is a very richly funded healthcare system. So I think, and many would say too richly, and that's fair. But I think as part of a transition to a national health insurance system, that will mean that we'll have the resources we need to continue to provide this sort of quantity of care we have now. If we move to Medicare for all, we're still going to have a lot of orthopedic surgeons. They're still going to be doing a lot of shoulder replacements. And so I'm not worried that there's going to be a long wait time for shoulder replacements. The truth is that if you want more of something, you do have to pay more for more of it. And I think that some of the shortfalls and some of the wait times that we do see in countries like Canada, in all fairness, that those could be remedied by expanding the investment of resources. On the other hand, I think that it's easy to focus on wait times for a relatively small number of elective procedures and sort of miss the forest from the trees in that for the so many Americans are on wait lists, they just don't even know they're there because they never get to see the doctor to begin with. And I think it's easy to sort of miss that.
Okay, so thank you all so much, and thank you to all of our speakers for answering the questions from the audience. I'll now turn it back to Aparna for some final closing statements.
Thank you. Yeah, I'd like to thank you all so much for being here tonight. It was really our pleasure to host you, and a huge virtual round of applause for all of our speakers and to Annika, our moderator for the evening. Now we actually have something to show you as a token of our appreciation. So at every single Berkeley Forum event, our communications team puts together a custom poster for all of you just to signify the event, and this one is no exception. So this was designed by Jui-Fen from our communication team for all of you. So at this point, if any of you have just some very brief closing remarks that you'd like to make to the audience before we close out completely, feel free.
I wish America, US, every luck to achieve universal health coverage in time soon.
Just to make a point, I think all of you live in a state that shows where we can be successful. Because if we look at it, and I should say at least the American citizens in California, we have virtually universal coverage. I think there are only a couple of percentage points of uncovered people. The undocumented is another issue. But you have through the system their complete implementation of ACA, and I think it works.
Sure, I'll close just by saying again, thank you for having us. Interesting discussion. I think the truth is that achieving big things always sounds extraordinarily difficult until you actually do it. And I think that this is going to be on the agenda for many years to come. And as long as we have the problems of uninsurance and underinsurance and insurance waste and the racial disparities and inequalities that the audience raised, as long as we have those, we will continue to be discussing this issue, and we should be. And I think that it behooves us to not just think about what's practical in the moment, but to think about what's the right thing to do in the long term. So thanks again. Very interesting chat.
The only thing I would add, well, I'd add two things. First of all, thank you for having me. It's been a lot of fun, actually. And I think what's interesting is you haven't really heard any dispute over ultimate objectives in terms of covering people, eliminating racial and other disparities, et cetera. There's a debate over how it is you get there in terms of what the mechanisms are. But I think in terms of ultimate outcomes, we're all in agreement. And to me, that's a little unlike the current American moment. And so I am gratified to have been part of the conversation.
Thank you for having me.
Yeah, of course. Yeah, great. Once again, thank you all so much for being here tonight. We really appreciate it. And to our audience, we do have more Berkeley Forum events coming up this semester. So next we will be hosting Mark Safarik, a member of the FBI's Behavioral Analysis Unit, on March 9th. And after that, we will be hosting Catherine Marr, the CEO and current director of the Wikimedia Foundation, as well later this month. And lastly, thank you so much for coming and spending your evening at the Berkeley Forum. If you'd like to submit any feedback or suggest future speakers, you can fill out the form listed here at this QR code. Also, feel free to like us on Facebook and visit our website at forum.berkeley.edu to keep up with any of our events coming up this semester. And lastly, if you are willing or able in any capacity, we ask that you help support us. Any amount goes towards putting on more events. So thank you all once again for spending your evening at the Berkeley Forum, and we hope to see you at another event soon. Thank you.
Thank you.